Hello, everybody. Good afternoon, good morning, good evening, wherever you are in the world. Welcome to the latest IMS webinar on VVA, the silent epidemic. We currently have over 1,000 people registered for this webinar, and many of them have joined already, so we look forward to welcoming you wherever you are. The IMS was founded in 1978, and one of our principal goals is to spread the knowledge around the world of women's health so that people can get a greater understanding, women have a greater opportunity to have access to equitable healthcare. And this series of webinars is one of our ways of trying to reach as many people as possible to give them this information. Today's subject is a very important one. There's a common condition that's associated with debilitating symptoms that really affect a lot of women. Unfortunately, a lot of healthcare professionals, a lot of women don't recognize the importance of this. So that's why this webinar is really important to try and address this and get us up to speed with the latest evidence and ways we can manage this. We are very fortunate we have two eminent and excellent speakers who are going to present to us this afternoon, Professor Rossella Nappi and Professor Marco Gambacciani. The presentations will goes one after the other, and then we'll have hopefully about 25 minutes to 30 minutes for Q&As at the end. The chat function is off, so if you want to post a question, please use the Q&A icon at the bottom and post your questions, and then during the question session, I will post the questions to the panelists. I do want to add that we are very grateful to Bessans for an unrestricted educational grant for running these series of webinars. I just now would like to introduce Professor Rossella Nappi. She is a consultant gynecologist, endocrinologist and sexologist at the Research Centre for Reproductive Medicine and Unit of Gynecological Endocrinology in Pavia, Italy. She's an international authority on the emotional and sexual impact of hormonal disturbances such as the menstrual dysfunction, infertility and menopause. She's published and lectured extensively on the physiopathology and psychobiology of reproduction, and she's currently General Secretary-elect of the International Menopause Society. Rossella.
Thank you. Thank you, Tim. Hello to everyone. I'm particularly pleased to be with you today in this live activity we have with IMS. And I really enjoy to discuss VVA because it's a topic of my research and my practice every day. Here my disclosure of interest, and let's start with
your
this.
screen, Rossella.
Okay, here we are. And let's start with my journey with VVA. And we began together with IMS in 2010, and you see that the World Menopause Day was devoted to the ending the silent suffering. At that time, we released the guideline for treatment of vulvovaginal atrophy. We will update for the next year together with Tim and other experts. And you see then in 2018, with a group of friends, we underlined the importance that VVA, and we will see with this new acronym, genitourinary syndrome of menopause, this condition has for sexual function at midlife, because sexual function, it's really important for women, both on a personal level, but also we believe it's incredibly important for longevity and for good quality of life for women. But even though we did this long journey, what we realized in writing this white paper on sexual well-being after menopause is that we still have a lot of work to do in order to help women and also practitioners to deal with the topic of sexuality and in particular of VVA. And it's very important to open the dialogue and to provide or facilitate the appropriate treatment. What we have learned about VVA and GSM over the year, it's really, as Tim said at the beginning, that this is a chronic condition affecting a large number of postmenopausal women, we will see in a minute, with a great impact on their life and well-being. We know for sure that biology is involved, in particular the significant hormonal changes, estrogen, but also androgen, aging uh, phenomenon, lifestyle factors, even the frequency of sexual activity and some comorbidities such as diabetes and obesity, some drugs, think about cardiovascular drugs or benzodiazepine, and other dimension of a partner's health. They are important, of course, from a biological point of view, but we have learned also that we have some other psychosocial modulators, such as self-esteem and body image of women, the way women feel about menopause and the importance they attribute to sexuality, and other aspects that have to do with culture, so the attitudes that women have towards menopause and aging, but also with their own experience and access. But what we have learned even more that this condition is highly prevalent, but it's underreported and undertreated. As I told you, some years ago in Chicago in 2013, to be precisely, a group of experts on behalf of the International Society for the Study of Women's Sexual Health and the North American Menopause Society, but there were some people like myself from IMS, they joined together and they spent 2 days discussing about vulvovaginal atrophy. And they propose a new definition that now it's really important because it gave a big impulse to research in this field. And why these people, they decided we should renovate in some way the definition of VVA for many reasons. First of all, because we want to put in a sentence all the different aspects and signs and symptoms that have to do with this phenomenon of vaginal atrophy, so urogenital and sexual symptoms as well. We want to expand the idea that not only the vagina was involved, but also the labia majora and minora, the clitoris, the vestibule, the introitus, the pelvic floor, and even the urethra and bladder. But probably the reason why this group really decided that we have to have a new name was because they realized that we need a new term that can be more acceptable in the medical and public arena in order to improve and increase communication, research, education, and management. Because indeed, as I told you, VVA at the time we proposed the World Menopause Day in 2010 and even after, it's still a medical challenge because we know this condition very well. You see from this beautiful cartoon by Gorham Sampson and even the seminal work that Gloria Bachman did in the 90s, that the urogenital aging is an old problem. We know about the condition, we know about the anatomy of the vagina, the way the vagina change with the menopause. You see in this beautiful picture, you have a loss of folds and elasticity of the tissue, you have a thinning of the skin, you have reduced blood supply, reduced lubrication. We know all this, and we know that these signs and symptoms occur very early. So we know the subjective symptoms of women, low lubrication, poor arousal, sexual pain. We know the objective diagnosis, but we have still a taboo because women, they don't tell, and doctor, they don't ask. And we really believe that by talking about the vagina more freely, women, they can tell to ourselves as doctors, and therefore we can help women throughout this process of taking care of vulvovaginal atrophy. And why women do not have easily talking about VVA? Because it's something that has to do with sex. I discovered that when I designed this international vagina dialogue survey with other colleagues. And the vagina is still perceived as a private and intimate organ. And women, of course, they want to have an open dialogue about the vagina. But we have to be aware that in the public arena, including the medical setting, all the data we collect in that vagina dialogue survey suggested that there is still a significant discomfort, even shamed, attached to discussing the vagina. And there are many barriers that has to do with the patient, not only because of age and education, but also think about women, they are not in partnership, but also because women, they feel really, really embarrassed and they are poor aware that this condition can be cured. On the other side, healthcare provider also, in some cases, they have an inadequate training. This is the reason why we are here today. And also, they perceive lack of time. And this is particularly true when you talk about sexuality, because doctors, they are always afraid that women, they will open the Pandora box talking about many dimensions of their life. And we have some kind of time constraint in our office. But also the doctors may be embarrassed, and some are poor aware that these symptoms, they are important for women and they are solution to solve the problem. And also there are some common knowledge that nothing can be done. It's part of natural aging process. And also we have to think about that sex should be considered a medical priority in healthcare. And this is not always the case everywhere. Another very interesting point to uncover the subject of VVA is related to the fact that we have this name, vaginal atrophy, but when we conducted a survey, the VIVA survey, and we did that on both sides of the ocean in North America and some European countries, but also in Latin America, as you see, we did that in 2018, we discover that women, they believe that vaginal symptoms are just something that is related to menopause and that it can be similar to hot flashes and they can decrease over time. So only few women, as you can see on the screen, 4% in North America and Europe and 6% in Latin America, they really name the condition as vaginal atrophy. So how you can talk about something you cannot name? VVA, it's an individual experience indeed, and is made of many symptoms. You recognize from the cartoon the anatomy, what you can observe in terms of changes of the vagina. We know this. These are the objective signs. This is the objective diagnosis. But before arriving in the office of the healthcare provider, women, they should feel a subjective experience of VVA, and they should report symptoms. And we have learned in international surveys, such as the Revive, I just reported the European data because we were conducting that study, that women have different kind of symptoms related to VVA. The most important one is dryness. You see that is followed by pain with sex, and keep in mind that some women, they stop having sex because of VVA, because of dryness. So what I want to say here is that the relevance of the symptoms depends on many aspects of women's life. And so for some women, dryness may be more important, for other pain with sex more important, irritation, tenderness, and so on. So it's a really diverse condition, and our ability should be on one hand to capture which one is the most bothersome symptom for our patient, and on other hand to recognize the objective signs. How we can do that in the office? We have very simple scales, and we use that to rate the most bothersome symptoms. We can go from 0 to 3. 0 is none, mild, moderate, severe, and we can list to our patient all the symptoms, the most common: vaginal dryness, dyspareunia, vaginal vulvar irritation, dysuria, bleeding associated with sexual activity. Keep in mind that this is a scale that is used also when we test in double-blind placebo-controlled trial any drug we want to propose to manage this condition. Then we have some supporting findings in order to objectify the condition, and it's important I underline that, for example, The FDA rules include the maturation index. What is the maturation index? It's like a pap smear in which you collect the cells of the vaginal fornix, and in which you can really count on the number of cells, superficial, intermediate, and parabasal. And you recognize easily from this picture that when you have less than 5% of superficial cells, this means that you have a vaginal atrophy. You can use also this in the office, of course, but it can be long, it can be expensive. So a very important surrogate marker that is strongly correlated to the maturation index, it's a very simple tool we have in the office, that is the vaginal pH, because we should keep in mind that when menopause occurs and in the absence of estrogen, we change very much the vaginal flora, the microbiota, and therefore pH is usually higher than 5. And this is a surrogate marker of vaginal atrophy. However, we should make also some kind of criticism to this approach of the most bothersome symptoms, and I want to share you these results to make my point. This is an analysis I did with Nico Brunick, based on one of the most recent trials that we conducted together on vaginal dryness and dyspareunia. At the time, we were studying ospemifene, a drug that was released in North America and Europe, in some countries in Europe, to treat vaginal atrophy. But what is very important and interesting from this slide to us is the idea that when you consider only the most bothersome symptoms, of course, this is good for drug registration purpose, as I told you, and it's an easy model because it's simple and it's scientifically validated, and you can say, okay, I use this drug, I can improve this symptom. But when you consider only the most bothersome symptom model, you may underestimate the total magnitude of the clinical benefits of a given treatment for symptomatic women suffering from VVA, because you do not consider all the constellation of other VVA symptoms. And this is true when you study anything, when you study a gel, when you study a laser, when you study a drug or local estrogen, or even the new release drug, progesterone. We should really consider the constellation and probably not only the most bothersome symptoms in clinical practice in order to really understand the full impact on the condition on women. On the other hand, in order to objectify the condition, as I told you, it's very interesting to measure the pH, but we can use a very simple scale that was released, as you can see, more than 25 years ago by Gloria Bachman, in which the doctor can objectify the condition. We can try to rate the overall elasticity of the vagina, the fluid secretion, we can try to quantify that, we can describe the appearance of the mucosa, and we can also describe the moisturizer of the vagina. And according to this classification, we can, in our routinary job, to quantify the vaginal health and to try to discuss with the patient all the effect that a drug can have. Because as you can imagine, since these symptoms are highly subjective, it's not like when you measure blood cholesterol or when you share bone mineral density value with your patient. And so to try to help the dialogue with your patient, you really to try on one end to find a way to measure the subjective improvement, but also a way to measure the objective improvement. There are also new scales, as Nick Panay in this beautiful editorial alluded to. This is a scale that another friend of IMS, Santiago Palacios, another expert on VVA, published, in which you can study also the vulva. because in this new definition of genitourinary syndrome of menopause, we have to consider that it's not only the vagina, but it's also the introitus, it's also the clitoris, and therefore, if we learn to describe the tissue, the entire constellation of symptoms related to the tissue, we can really improve our ability not only to diagnose, but also to treat. And indeed, when we do that, we really capture the impact that the condition has on the patient. And I want to share the full table of this survey that is the last we conducted on a big number of women on VVA in Europe. And you see, this is a table that put together subjectivity and objectivity. You see here we collected in the clinic, so not in a general survey like the number I shared with you before, in which women, they were suffering more or less 1 out of 2, so 50% of women overall report these symptoms. But here we are in the office, in menopause clinic, and you see that in menopause clinic, the women coming, it's really an epidemic. It's really like we said at the beginning in the title, because around 80% of women, they report VVA. But you see that when you put together subjectivity and objectivity, this number, it's really high and means that you may really diagnose properly the condition. Because you see there are some women, they report symptoms, vaginal dryness, for example, pain during intercourse, but these symptoms can be there, but the condition objectively is not there. So why I'm making this point with you? Because what is essential to me is really to understand together if we have to treat the symptoms or we have to treat the signs. Because as doctor, we are used to treat what we see with our eyes, but we have learned that women, they are suffering before the condition is clear, because you see that vaginal dryness is reported in 67% of women, and pain with intercourse in 51%, even though when the physician is not able to rate on the vaginal health scale that the condition is there. And this is essential to us, and this is the reason why we really need to consider very simple information to try to address the topic of vulvovaginal atrophy. And the most important symptoms is for sure subjective dryness. We have learned that these symptoms can be present even before the menopause in a small percentage of women. And these women, they are the one they will develop later on more problem with their sexual function and with other urogenital pathologies. Of course, pH can be measured, and pH is very easy because you have to rule out, of course, infection at the meantime, because sometimes this information is not so precise. Of course, you have to check for other allergies, for example, or other pathologies, they can be involved. And of course, then we may collect the most important objective signs, such as pallor, rugae, or petechia. But subjective dryness should guide us. And why this? Because we realize that if we do not discuss the topic of dryness, it's not a question of making the diagnosis in the office, but just discussing the topic. Women, they are not treated. You see, in the one of the analyses of the Revive survey, we realized that in many countries in Europe, those women, they were discussing VVA just because of discussing the symptom, were twice as likely to be current medication users for those who had not discussed it. Meaning that if women, they don't talk about vaginal dryness, they are not receiving any kind of treatment. And therefore, if they discuss, the healthcare provider can, of course, make also the objective diagnosis and to try to prescribe a treatment. And why this is so essential to conclude my talk? Because in a sub-analysis of the IVS study I showed you before, What we realized together with Nick and Santiago Palacios and other friends, that symptoms, severity, and quality of life in the management of vulvovaginal atrophy is quite odd. Why this? Because women they are treated, they are the one they report more severe symptoms. More vaginal dryness, as you can see from the picture, more pain during intercourse, more bleeding with intercourse, all more symptoms. And this is quite odd. But it's not odd if we consider how is this uncomfortable dialogue. And this is the reason why healthcare provider and gynecologists play a crucial role, because you can uncover the issue of VVA even if you are a general practitioner, and of course you may need the collaboration of the gynecology to objectify the condition. And we have to follow a very good frame of mind. First of all, to facilitate this discussion, recognizing the condition, we should be sensible, of course, to the impact on sex and quality of life. We really need to recognize that sexuality is important. We have also, however, to educate about risk factors and consequences, because we know that these conditions start already during the premenopause, and we need to understand the need and expectation of women, removing barriers, fear, misconception. And then we have to propose an option, a treatment. I don't want to go too much into details about the treatment, because I think our goal today it's really to understand that women, they have to understand all the different treatment we have. As physician, we have to consider the benefit-risk balance for any treatment we can propose, but our goal should be to effectively treat with VVA, and we really need to start early to obtain a better response to treatment by improving long-term adherence. And we said all these things also in our guideline in 2010, the one we will update very soon. And what we said at that time, that we really need to restore on one hand the urogenital physiology, so objectivity, but we have also to alleviate the symptoms, and treatment should go on because this is a chronic condition. At that time, we have local estrogen out there, only local estrogen, and we said that every local estrogen preparation were effective, and we really need to let our patient select what they prefer. Over time, we collect more information. We know that these products are extremely safe, but in terms of thromboembolic risk, breast cancer risk, that we can combine this treatment also with systemic HRT, because for some women, systemic HRT, especially low dose, is not enough to relieve completely the symptoms. What is essential to remember is when we consider the impact that local estrogen have on sex life and quality of life of the couple, what we realized in this study, that was the closer survey, the first survey in which men and women with VVA were interviewed, you see that sex improves significantly, not only for women, but also for men. And so when we propose an effective treatment, we really improve the quality of life and well-being of our patient. Now, in the meantime, we will update the guideline. I share, and this is my last slide, the update we did with EMAS and North American Menopause Society on different treatment, and you recognize topical and systemic hormone therapy, and we should include in topical not only estrogen nowadays, but also vaginal dehydroepiandrosterone, and even data on local testosterone cream. We should include the ospemifene non-estrogen oral treatment, and of course, lubricants and moisturizers, alternative and complementary therapy, and the laser. Marco Gambacciani will talk in a minute. What it's essential that we should tailor the right treatment to the right women, depending on symptomatology, severity of VVA, GSM, taking into account many aspects, preference, contraindication, but also going on studying more this condition that is so important for quality of life and well-being of women. And with this, I thank you for your attention.
Thank you, Rossella. That was lovely, and it's really helpful to hear that. And it just listening to you highlights what a huge impact you've had on this field in the last 15 years or so with all the research you've been doing. So thank you again for that. We're now going to move on to our next presentation. There's questions coming in, and keep them coming. We'll deal with those at the end. But our next presentation is Professor Marco Gambacciani. And while he's loading his slides, I just introduced Marco. He's a professor of obstetrics and gynecology at the Santa Chiara University Hospital in Pisa, Italy, where he's been director of the menopause research clinic there since 1987. His clinical and research focus is on gynecology, and in particular the menopause and osteoporosis. And more recently, he's been one of the pioneers in the research on the use of laser in gynecology. He's a founding member of VVA Academy, and he is well known for his work internationally. He's a previous board member of both the IMS and EMAS, and is currently the secretary of the Italian Menopause Society. So Marco, over to you.
Thank you very much, Tim, and good afternoon, everybody. It's my pleasure to take the podium after Rossella. And my task today is to talk about the laser for VVA, or as Rossella told us today, as a GSM treatment, and dealing with both benefits and possible concerns. These are my disclosure, and I can tell you that unfortunately, I don't have any financial interest in any laser company. And the question is today, we do have a lot of possible treatments for VVA or GSM, if you wish. And we can go from moisturizing creams, lubricants, vaginal estrogen therapy, HRTs at the proper dose, as Rossella said, or the new Spimfin and the latest in Italian market, for example, the DHA, the progesterone, that are wonderfully working for the relief of signs and symptoms of our postmenopausal women. And the question is today the laser an evidence-based option? And for that, I'd like to, I'm stealing now one of the Team Hillard slide that Tim presented in our last VVA meeting in Florence last November. And Tim really summarized all the data we do have on the all the publication we do have for the treatment of vaginal atrophy with a laser. And basically, the main message is that we do have a lot of observational studies. We do have just one or two controlled trial with the sham treatment, with a kind of placebo-treated treatment that is mandatory for postmenopausal women when we are dealing with signs and symptoms. So we are dealing with something that is referred from the women. And but we do have also wonderful data from these observational trials. All of them are unanimously demonstrating that the estrogen, the laser is working quite well in reducing signs and symptoms. This is a meta-analysis that was compiling all the data available in women treated with the CO2 fractionated laser. And as you can see, dear colleagues, all the data clearly demonstrate that a laser improves all the signs and symptoms of vaginal atrophy.
Mark, can you go to full screen? Could you go on to full screen?
I will do it. Okay.
That's better. Yeah, thank you.
It's better. Okay. So all these data showing that for dryness, dyspareunia, itching, burning, the CO2 fractionated laser is working wonderfully in reducing these signs and symptoms. I'd like to underline that these data were obtained with one machine, the one Italian machine. And I'd like to underline that in the world of energy-based device nowadays is a kind of jungle, because from two different lasers the CO2 Italian lasers and the erbium YAG laser with a smooth technology in 2010, just in 8 years, we did have dozens of different energy-based devices. And the vast majority of them, I'm afraid to say that they don't have a data. Even CO2 lasers, they are quoting the data that were obtained with the original CO2 fractionated lasers. But this is not fair. Why I'm saying so? Because each machine has its own technology, and the tissue laser interaction varies accordingly to the different technology. So each one of these 30 CO2 lasers should provide original data to demonstrate efficacy, and first of all, to demonstrate safety. Why I'm saying so? Because the CO2 lasers is an ablative laser, and therefore, while we do have data for the original CO2 fractionated laser, that the effects on the tissues are safe, even if they do have a longer downtime than with a smooth technology, all the other lasers, they don't have any kind of safety data or even efficacy data. So not all lasers are created equal. And why we did choose 8 years ago to work with the erbium laser? Just because the erbium lasers is not ablative at all when we are using the smooth technology. And this is important, because in this way we can assure that we don't have any tissue lesion at all. The mucosa, the vaginal mucosa is not ablated. We don't have pain during treatment. We can treat not only the vaginal canal, but we can treat also the introitus and the vulva. Also because Rossella told us that the atrophy is not only in the vagina, but it is in all genitourinary system, including the vulva and the urethra. And with the erbium, we can treat inside the urethra just because we don't have any ablation. And we do have now a probe, 4mm probe, to treat inside the urethra. And practically, we don't have any downtime phase because we don't have any tissue healing problems. And the erbium smooth laser is the only energy-based device that is not ablative, is completely operator independent, because all the procedures are presetted, and we do have a large database available with scientific evidence of large prospective studies. We do have nowadays more than 55 papers published in international journals, and in a few months is going to be published also the proceeding of the last VELA meeting in Florence, held in November 2019, where all the latest information are going to be available. I'd like to remind to the guys that are not familiar with this technology that the treatment with laser it consists in two different step protocols. One step is the full beam treatment of the vagina by 360 degrees adapter. So all the mucosa is treated, is not fractionated, the treatment inside the vagina. While the second step, the treatment is a patterned beam, and we can treat all the vestibulum, and when we need, also the vulva. We do use 3 different sessions, 30-40 days apart, and basically the tissue laser interaction lead to a vasodilation and an increase in neocollagenesis. This is the bottom line. With the temperature, the thermo treatment induces a vasodilation and an increase in neocollagenesis. As I said, that this technology is very easy to be performed because all the parameters are preset, all the procedures are validated by the company with a minimum variations between different, among different operators, with different programs that are all preset inside the machine. So the techniques are really reproducible and therefore is appropriate for even multi-center trial. As this is the aim of the Vaginal Erbium Laser Academy, the VELA, to have a large database obtained in different centers. This is appropriate just because we do have a reproducible technique. Let's go to the signs and symptoms. All the data you are going to see are obtained with 3 different laser applications. And in my slide, you'll see L1, laser 1, laser 2, laser 3 every 30 days. And all those women that are going to see in my slides were not treated with any kind of local treatment, hormonal or non-hormonal. So all the data should be ascribed just to the laser effects. And these are our own first data. You see the effects on dryness and dyspareunia in the percent variation, the visual analogy scale on the 10-point scale. You see L1, L2, L3, a decrease of about 40–60% of dryness and dyspareunia with the Gloria Bachmann index, as Rossella said before, the vaginal health index score that is increasing after the first, the second, and the third. And I remind you that the 15 is the border between the normal vagina and the atrophic vagina. And you see all these patients were really atrophic at the beginning. But the 2 questions that always are being asked is how vaginal erbium laser results can compare with the standard treatments and how long the results can last. And Adrian Gaspar, that was the very first one that discovered this possibility to treat the vagina with the laser. Adrian was starting his work with the CO2, and afterwards he shifted to the erbium laser. And thanks also to his work, I was really convinced that this is the way to go. You see, the erbium laser, in comparison to estriol, is superimposable in terms of the effects in the first months. After the treatments, you see this almost superimposable. But when you stop the treatment, the local treatment with estriol, in the group treated with estriol, the dryness comes back again. And the same was the results in a larger group of 200 women. We followed for 2 years. You see, these are our data. There are 2 groups of women that are really comparable in terms of age at menopause, years since menopause, and BMI. And you see the results. L1, L2, L3, decrease in vaginal dryness and dyspareunia. And the women treated with the local treatment, you see for the first 3 months, the effects of laser and the local treatments are superimposable. Conversely, when you stop the treatment with the laser and you stop the treatment with local treatment in the control group, in the group of LT, the local treatment group, you see that both dryness and dyspareunia as expected, because as Rossella said, is a chronic and progressive condition, the VVA, and therefore the symptoms, they come back. While in the women treated with the vaginal erbium laser, you see that the effects on dryness and dyspareunia can last at least 1 year. After 18 and 24 months, these 2 points are no longer statistically different from baseline. So we can say that the effects of laser can last 12 months in terms of dryness and dyspareunia. And by the way, in brackets, I will say that also the effects on stress urinary incontinence is quite similar in terms of timing. And these are our own data. And even if this study was not randomized and is not controlled by a placebo or a treatment without the beam, effective beam, I can tell you that 173 women out of 205, I mean 84% of them, they ask to repeat the treatment, and as you can see, after more or less 12, 18 months, suggesting that the vast majority of women, they feel the benefits of treatment for 12 months, and afterwards they ask another treatment to improve their vaginal conditions. And this is one piece of information that for me is really important. This is a group of postmenopausal women after breast cancer. And I'd like to underline, as you can see here, the age of these women. They are very young. And the vast majority of them, they couldn't have sex due to the aromatase inhibitors effects, and they cannot stop the aromatase inhibitors. So even if some of them, they ask to stop the aromatase inhibitors due to the side effects, including the vaginal effects. And as you can see with the laser, we can improve dryness and we can improve dyspareunia. And once again, the effects, as you can see, their colleagues last at least 1 year. That is quite important for these women to have an improvement in sexuality. And in fact, you see in these women, the FSDS clearly demonstrate with a reduction that of the score, that the effects of laser are present in terms of sexuality after the second and the third. And once again, the effects is maintained for 12 months. Even if the number are is a small group of women, the results are quite encouraging. And in fact, as a VELA, we have done a large study, again, observational study, including 47 Italian centers, and we have data on almost 1,300 women. And these are the results that are going to be published in the issue of Climateric devoted to the proceedings of the VELA meeting, showing us the effects on FSFAI of vaginal erbium laser in terms of desire, arousal, lubrication, orgasm, satisfaction, pain, and in all the total score, demonstrating the leading effects of vaginal erbium laser as other local treatments in terms of sexuality. And these are the effects in terms of FSDSR. You see here in 554 different women with a mean age of 54, you see the effects of vaginal erbium laser in terms of sexuality with an improvement that is statistically significant. Even if our observation is short and is being a huge observational trial, we were able to get all these numbers just for 6 months. What about safety concern? The safety concerns basically was originated by a strong marketing pressure. And everything originated back in 2018 when the FDA was forced to send letters to USA distributors of different lasers that they were promoting their machine for the indications that they were not allowed in the United States. All these energy-based devices were registered for the destruction of precancerous cervical and vaginal tissues. But in the meantime, all these distributors were promoting their machines for vaginal rejuvenation. And this vaginal rejuvenation was really disturbing our North American colleagues. And they were starting a kind of lobbying against the use of lasers. And as Vela, we released in a mini review this statement that the FDA announcement is primarily a warning to laser manufacturers not to promote their device for unapproved gynecological procedures. But these gynecological procedures, even if done with CO2 lasers, as I said, they are macroablative. They are ablative, but they are microablative. And please, dear colleagues, take a look to the numbers. This is a case report paper that was cited many times in different congresses. Rethinking the technovagina, dear colleagues, 4 cases, over 1,000 cases treated with the same ablative lasers in the United States. And also the largest database that we do have in the North America, the MODE, that houses all the reports submitted by manufacturers or doctors or whatever on side effects of different machines. You see, they collected 46 cases of patient-related injury, operator-related injuries, device malfunction or not specified. So actually, we are talking about nothing, okay? Out of 1,000 of laser treatment with microablative CO2 lasers, everything, the maximum we can say they collected 46 cases. The vast majority of them was just pain during the procedure. And to say what I personally see, these are the first 389 patients. Just one patient defined that the treatment unacceptable. The vast majority of them defined the treatment with a vaginal nervous smooth laser excellent or good, or if you wish, in terms of a single procedure, the efficacy was considered high or moderate in 653 after 653 procedures out of 1,100 procedures. Just one, the same patient, was defined that the procedure unacceptable in terms of tolerability. But the vast majority of them, 1,100 out of 1,100, 1,000 patients can actually define the treatment, the tolerability good or excellent. But as a Vela, we'd like to have the final word in terms of laser safety after the FDA warning. And for that, we collected data from 130,000 patients and revising everything, revising all the data, and we collected and we published the data. We are going to publish the data in the proceedings. These are the original tables presented by Zenko Visentin in the Vela meeting in 2019. You see the overall frequency of these side effects is 4%. And please, dear colleague, take into consideration that was referred to the vagina discharge. Then in my personal view, is not a side effect, is what you do expect after thermotherapy of the vagina, as I said before, the vasodilation, that actually is it lasts for a couple of days and no more. With the vaginal nervous smooth laser, therapies have been registered in the European Union, Australia, Singapore, Canada, Taiwan. All the certification received are for treatments, not only for the machine, but also for treatment for stress urinary incontinence, the continence, vaginal relaxation symptoms, and the VVA. And as Italian Menopause Society, we endorsed the treatment with the laser in the recent onset of menopause, in the late stage of menopause. We didn't say that we can treat that is because this laser can be applied in perimenopausal dryness just because we don't have any available data published in any journal treating women in their perimenopausal years. But all the data are confined in women after the menopause, either recent menopause or late menopause. But today, I'm not gonna say that the laser is the treatment, the only treatment. In my personal view, laser is one of the best treatments for VVA or GSM, if you wish, but we are going to go versus an integrated approach, also because, as Rossella said, the VVA is a chronic condition. So women can, they have to face a VVA for 30 years. It is not feasible that a woman can have the same treatment for 30 years. So hormonal treatments, non-hormonal treatments can really be associated with the vaginal erbium smooth laser because mainly the veil is effective, safe, and reproducible. It's a non-ablative technique and is really available, and it is really the best one to be repeated over time. And is completely operator independent. But the key points actually is the patient selection, discuss with the women the other options, and after an extensive counseling, offer realistic expectation. We cannot say that it's gonna work 100% in under 100% of the women. And having said that, I'd like to thank all the guys that helped me in these years, from Jorge Gaviria, Adrian Gaspar, my friend Ivan Fistonich, and all the others friends that all over the world allow me to get information and new knowledge on laser. Thank you very much. Grazie for your attention.
Thank you, Marco. An excellent overview of the laser. We are sort of coming up to 3 o'clock, but we're allowed to continue for a while. So I want to get some questions. We've had lots of questions coming in. So I'm just going to go straight into some of the questions. I do apologize. There's lots of questions. We're not going to get through them all. So I'm just going to have to select a few. But I just wanted to pick up one, which I thought was a very important question about cervical cancer. We know that menopause is not associated with an increased incidence of cervical cancer, but I think that the theme of the question is whether the presence and reluctance to seek help for vaginal atrophy may impact on either the presentation or the screening for cervical cancer. And Rossella, I didn't know if you wanted to comment on that.
Yeah, I can make a comment. I mean, we don't have data suggesting that women suffer more from cervical cancer because they are not diagnosed really because of VVA. But for sure, what we know that having VVA is a barrier to go to see the doctor, and there are women, they have an extremely severe picture of VVA, and this is really an obstacle sometimes to make the genital examination. So we really need to be extremely gentle to these women, and there are data suggesting also that preparing the mucosa to do a pap smear, this is essential to have a good quality pap smear, because we have data out there suggesting that we have some kind of metaplasia, what we name ascus, that is much more common, metaplasia in women because of VVA. And then maybe you screen these women for HPV or other condition, and they are scared that you do colposcopy, And then if you just give them hyaluronic acid or local estrogen, you can completely reverse the condition. So we really need to consider and do more research on this, actually.
Okay, so we're getting lots of questions about breast cancer. Marco, you talked about laser in the use of breast cancer. Do you want to just expand a little bit on where you think this potential role for laser treatment is?
Oh yes, because as I said, the women that survive, thanks God, the vast majority of women they survive breast cancer, but the new treatments like aromatase inhibitors are devastating their sexual lives, not only the bone, but also their sexual lives. And as Rossella said, the hyaluronic acid for treatment of vaginal atrophy is excellent, as other lubricants or moisturizing are excellent, but women get annoyed to that. So the laser is an option, mainly in young women. And since young breast cancer women are very young, the youngest of my patients published 3 years ago, she was 38, you know, and so we need to repeat the laser every other year maybe, and we want to. That's why also I'm in love with a non-ablative technique, because we know that we don't use any damage in the tissue. And therefore, the tissue can be treated many times during the past years. And I know I can't prevent your question. We don't have data. We don't have data in repetition of it, but the idea is that without any ablation, having microablation, we don't damage the tissue. So there are no repair of the damages. So hopefully we can repeat safely every other year.
Rossella, anything you would like to add on the breast cancer patient?
You know, I really believe that we should educate women. And, you know, when I see the guideline, they say, okay, you should go on with your moisturizers and use lubricants. This is something that we should discuss more with women, because I agree with Marco that women, they don't like too much to go on. We know that adherence to the treatment is poor for women, for local treatment in general, but it's also because women, they do not understand that it's a chronic condition that goes over time. Because think about the women, they put cream on the face every day since they are 20 to when they go, and you know, it's just a question of understanding and education. And of course, if you can go faster by using this laser or radio frequency or whatever you want to use, thermal energy, this can be, of course, useful. But we have really always to balance benefits, risk, cost, and you know, and time, a lot of things. And also we need more data. But for sure, we should educate women. This is my first goal in this business.
So carrying on with the theme of education, Rossella, there's another question about whether we should be having an awareness program for around the world for women to try and educate them more about the problems of the menopause, and in particular the vulvovaginal atrophy symptoms.
Yeah, thanks for this question. This is something I'm thinking very much, and I believe that we can plan maybe the IMS or all the societies together to do really education, like when we want to educate that you have to wash your teeth 2 times, 3 times, anytime you eat, or because women, they should understand that this is a part of their body, and according to different age in reproduction, pre-menopausal, post-menopausal women, even during adolescence and in infancy, you really need to have a special intimate care. And if we put VVA into the more general idea that vaginal health is an important part, like cardiovascular health, bone health, and this and that, because it's essential for your sexual life and well-being and happiness in life, we will do something. We should always be careful about the culture, because it's beautiful to have an awareness project, but we should really tailor the program to the culture, because we are not the same as Asia, Africa, North America, South America, Europe, and etc. So we really need to be sensible.
All right.
Okay.
Yeah, absolutely right.
Okay, Marco, several questions about the cost of laser. I mean, I appreciate it's going to vary depending on where you go, but can you give us an idea?
Yeah. For example, in my department, the Department of Studying Gynecology in Pisa, we do have free for women treated for breast cancer. Women treated with hormone-dependent cancers, mainly breast cancer, endometrial cancer, they do have the treatment for free. Usually the price varies in different countries around the world. This goes from 200 euros to 300 euros each time. So actually this is quite expensive. But actually in Italy, at least in Italy, the vast majority of companies, they reimburse the treatment. Also partially, sometimes partially, but they do reimburse the treatment. So the treatment is very expensive, I should say, but is again is something that, as Rossella said, we have to balance, the cost, the benefits. Maybe we can, in the practice, all these data were obtained with 3 treatments, okay? But I shouldn't say that because I don't have data, but if you improve the vaginal atrophy after 1 treatment, you can keep going with hyaluronic acid suppository or estriol local treatment or general treatment. For example, the vast majority of my patients on low dose systemic HRT that, as Rossella said, is not effective in 75% of the women against the vaginal atrophy. With just 1 session a year, they feel better, and maybe it's enough. Again, team, I don't have a formal data to suggest so, but actually in the practice it works, Women they do have an improvement in vasomotor symptoms, insomnia, headaches, and so on and so forth with a low dose, continuous combined hormone replacement therapy. They don't have an improvement in the vagina. With 1 session of vaginal erbium laser, you do improve it. And the effects can last for time in the time. So one problem in the VVA story is the time consultation, because as Rossella said, we need the time to explain everything, and to explain that after 3 months of estriol cream, the VVA does not disappear, is cured, but for the time that you are taking the estrogen, local estrogens. Afterwards, it goes back, because it's a chronic and worsening condition. And this is not easy to be understood. But we need the time to explain to our patients everything. That's...
So, following on from that, Marco, can you just make a comment on who you think should be doing laser treatment?
Oh, actually, maybe just because I am a gynecologist, but I should say that is the gynecologist that has to do the treatment. Why? Because I said in one of my last slides, patient selection and counseling are critical in terms of the outcomes of the treatment, and therefore only the gynecologist knows everything, or should know everything about a GSM or VVA, and therefore only the gynecologist can explain the pros, the cons, and everything of different treatments, including laser. And therefore, the laser must be done by a gynecologist. At least this is my personal opinion.
Okay. Rossella, do you want to make a comment?
I think that the OBGYN, or at least the healthcare providers such as midwives or other nurses with a special training, should be the one entitled to deal with the vagina. I really do not believe that aesthetic surgeon or aesthetic people, they have the deep knowledge in terms of physiopathology of the condition. And also keep in mind that many aspects related to reproductive life and sexuality are extremely important to understand the impact, the relevance, the clinical relevance of signs and symptoms. And so you should be really in women's life to be able to really understand if you are proposing a treatment in the appropriate way, because otherwise you will miss the object. And maybe you will treat a woman, she has vulvodynia, or she had scars during delivery, or she have hypertonic floor because she was, we should say, also domestic violence or other stuff. I think we really need to be careful. And therefore, I believe this is it.
Completely agree with that. Rossella, just a question on safety of a lot of questions coming in about vaginal estrogens and safety. And can you just update on the latest sort of safety evidence for vaginal estrogens? Because there's often a concern that is raised about vaginal estrogens.
Yeah, you know, for the lack of time, we were not discussing that, but you know, we know since a long time that local estrogen are safe, especially now that we have low dose preparation. So the 10 microgram, 4 microgram gel, the 50 microgram estriol, and all the analysis that have been published at present suggest that there is no increase in thromboembolic risk, and I may say also no increase in breast cancer risk, and also keep in mind no need for adding any kind of progestogen because of fearing endometrial cancer. So I really believe that even in breast cancer patients, when they are cured, this is my personal opinion, with discussing with the patient in all the cases in which these hormones are needed, we can discuss with the oncologist, and maybe also for short period of time, we can propose that in people they are not using currently aromatase inhibitors. But for example, in tamoxifen women, we can propose, especially when they are cured. Of course, we have many other options. We have also, as you know, in Europe, we don't have a restriction in the use of some oral ospemifene in women they are cured, so they complete their chemotherapy and they are cured for breast cancer. And of course, we have also progesterone. Don't forget, in some countries we have this special DHEA that it's really at the present moment one of the possible option, safe option also in breast cancer patients. But we wait for the data.
Thank you. I'm just conscious we're running out of time. Really, it's just interesting to see the questions coming in from all over the world, really from Kathmandu all the way to Central America and all points in between. So we're reaching far and wide. A lot of questions about availability of various products in different countries, but I don't think we can really answer that. There's too much variation to be able to go into that in detail, because it varies even within Europe, let alone outside Europe. So I think I'm afraid we can't really specifically answer that question. But there's one final question, Marco, for you, which I think is interesting, about the use of laser in women who've had previous vaginal brachytherapy or who've had radiation in the vagina, whether you have any experience of that.
Yeah, thank you, Tim, for this question. It's quite important because in a lot of women, they had colon cancer. They had the radiation in the pelvis, and now we are start working with the radiation department, the radiology department, in order to start treating vaginas before and during radiations, in order to maintain with a laser, try to maintain the laser, the elasticity of the vagina that can be destroyed by the laser. Yes, brachytherapy for cervical cancer is a very important issue, but is quite rare. Colon cancer is very common cancer, And in women treated with surgery plus the radiotherapy, the vagina can be destroyed by radiotherapy, and the laser can be an option in order to maintain the vaginal functions. This is a very, very important issue for the women.
Are you not worried if the tissues have become very thin, will it respond in the same way, do you think?
Yeah. Actually, in women treated with radiotherapy, we need more than 3 treatments. There are patients that have been treated for 8, 9, 10 times every 20, 30 days in order to stimulate the vascularization again and to induce a neocollagenesis again. And it's very hard. That's why I said we are trying to start a study in order to treat colon cancer women just before and during radiotherapy in order to see if we are able to prevent the deleterious effect of radiations on vaginas.
Okay, thank you very much, Marcus. And finally, Lorenzo, just one final question. A question of age limit and the use of vaginal treatments, particularly vaginal estrogens. Is there an age limit?
I think we don't have any published data suggesting that we should have an age limit. We can start estrogen local therapy at any age. My practical suggestion is always to start with very low dose, because sometimes the tissue is so sensitive, that is so damaged, that even the right treatment can increase at the beginning burning, itching, discharge or bleeding. And we can go on for the time the woman feel she need the treatment. Of course, we have to check on our patient regularly, especially if she has some kind of symptoms such as bleeding or discharge, but we don't have time limit restriction.
Okay, thank you. I think we should draw it to close now. We're well past our finish time. I'd just like to thank everybody who's attended this. We still have 350 people on the webinar, so hi to everybody, and thank you for your patience. Lots of comments. Lovely to engage with you all. Thank you particularly to Professor Rossella, Nappi and Marco Gambacciani for their fantastic presentations and such a thorough answer to all the questions. So I'm just going to finish there, and what I'd like to do is just remind you of our next webinar, which is going to be on the 15th of September. This is going to be, note the time change, it's going to be coming from Central America, so just be aware of the time change from that, and we will look forward to meeting you all again then. So thank you very much for all your contributions. Have a good day.